Person-centred care is about tuning into the needs and concerns of the person that you're dealing with and allowing them to say what they want assistance with, finding out what's important to them and addressing their needs in a way that they find acceptable.
To support an individual really well, it's really useful to understand how their life has been, what sort of work they've done, what they've enjoyed, and that provides a lot of guidance for how best to care for that individual.
Clients have said to us that trust is the most important thing. So they need to know that they're going to actually get continuity of care, that they're going to have familiar faces and usually like a small team, because there's still quite a lot of stigma around the diagnosis, particularly for some people from different cultural backgrounds. Anytime we speak even to other health professionals, we have their permission to do that.
It's really important that the people in that person's world are across what it means, what that diagnosis means and what it will mean in terms of providing the best care for that person. And so issues around understanding that treatment is vital, supporting the individual if they have symptoms, and especially if they have difficulty remembering to take their medications, that's an important aspect of their general care.
When communicating with somebody with cognitive changes, it's very important that you speak clearly, talk about things one step at a time. You know, this is the problem, these are possible ways that we can get around it, and this is how we're going to tackle it. And that's a collaborative approach between you and the person with the diagnosis. Tune into whether someone is taking on board the information you're giving them, and if they appear to require more clarity, you might repeat that information a number of times. But it's also very important that you don't speak in a condescending tone. Some of our clients like us to write things down because they feel if it's written down, they can refer to it when we're not there.
Sometimes we do need to have difficult conversations. You may notice that someone's memory seems to be declining, or they're forgetting, they're becoming a little bit more disorganised. You need to try and address this with them.
It can be very confronting for anybody if somebody challenges how well their brain is functioning. All of us might feel a little defensive about that, but it's worth getting that conversation started.
If you're going to raise a concern that someone else may be struggling with mental health issues, you need to find the right time and the right place, and to do it in a way which is not finger wagging, which is not saying you've been living an unhealthy lifestyle so no wonder you've got these issues, or using stigmatizing language in particular. It's very easy for us to do that. So you need to be sensitive to finding the right time and the place to raise these issues.
You could ask the person if they're aware of any changes, or if they're aware that their memory may be declining, or that they're having more trouble in organising themselves. Once you've had the conversation with them, you can come up with a plan that they're happy with as to what the next step will be.
So I think it's important to think about HAND in the context of wider mental health and well-being issues, and to recognise that there are very high rates of depression and anxiety in this group of people.
It's important for carers to think about their own beliefs and attitudes that they may have regarding HIV and sexuality, and also around dementia, because negative beliefs might affect your ability to show empathy and to provide good support to the person that you're caring for.
Yes, I've had 2 episodes of clinical depression, and I'm very well maintained. The wisdom is, the medical wisdom at least I received, was that after 2 distinct episodes that you remain on antidepressants. And so I'm on a selective serotonin reuptake inhibitor.
When people get a diagnosis of cognitive change, they can become very isolated in their own world. They lose a certain amount of confidence. They tend to spend a lot more time at home. They don't go out. They become socially withdrawn, and they can become quite lonely. So it's very important that people are encouraged to make the most of what they can do and try and get out and see people and do other things. And there's still an awful lot they can do. They just have to do it slightly differently.
We have very good evidence that peer support is one of the most effective ways of engaging with people with a chronic illness, which can be socially isolating. people with HIV, with a similar background, similar experiences, to come together, and that they can build skills together, and most especially build resilience to deal with the impact of living with HIV.
The people around the person who has that illness are challenged in terms of needing to give a lot of time and understanding, patience and forbearance to try and make the person they care for, to make their life as good as possible in terms of living with their illness, getting the right treatment, getting the right medical appointments and timing. But it can be exhausting, and there's very good evidence, broadly speaking, that carers of people with mental health problems and dementing problems suffer tremendously, and in fact are at risk themselves of very similar illnesses. So I think it's really critical that carers, including professional carers who may have a heavy workload of people with dementia or mental health problems, seek advice and support and care as needed.
Sometimes our visits can be more for the carer than for the client, and that might be around strategies as to how to care for that person, or education about some issues that they may have, that the client might not be that concerned about, but the carer is.
It's very important that we empower people to do as much for themselves as possible. So we would be trying to assist people to continue with all the daily tasks, such as cooking and dressing and social engagement. If the person is unsure or lacks confidence in performing daily tasks, a carer could work with them in order to enhance their independence, not to do things for them, but to empower them to do as much for themselves as possible. And by so doing that, that builds their confidence and allows them to believe that they really can do things for themselves.
In many cases, you can still complete the things. A person with YOD will complete the things that they would have completed, but it's slower. One of the things that I've found very hard to adapt to, probably the only thing, is that a lot of people feel a tendency to consider helping taking you away from the task and doing it themselves, which is not helping. And that's about the only thing that upsets me when someone does that.
People with cognitive changes don't have to stop doing what they've done before. They don't have to stop participating in the community. They don't have to take a different role in the family. They just have to learn to do things slightly differently.
We know that, especially for HIV dementia, helping support people to have good adherence to their medications is vital, because that's the only treatment we have available for HIV dementia, the very antiretroviral drugs themselves.
Some people do need assistance with their medicines and how they're going to manage them. So what we do is we try and set up a system that works for that individual. Some might need minimal help, or they might just need some help initially to organise their medications into a box and know what they all are, and some education about what the actual medications are. But others do need additional support and what we'd say care coordination around their medication, so that it can include organising prescriptions, making sure they've always got enough supplies, making sure they've got money to pay for it, they're not going to run out, making sure they've got appointments to be reviewed properly by their GP, or it could be their hospital doctor. So that can be quite intensive support, but usually, once again, we always try and encourage them to get as much independence as they can with their medications. It's just if they're on, say 10, 15 different medications, it can be very difficult for someone planning and organising.
We use calendars for people to prompt their memory. We also might use electronic devices and diaries, pill boxes, so that their medications are in order, so they can see quite clearly whether they've taken their medication.
My sister got me a 5-day pill tray box so that I could just put my pills out once a week.
Currently, we're really fortunate because a number of the new HIV antiretroviral drugs have relatively low toxicity and a relatively low pill burden. So what that means is that an individual may be able to take few tablets each day with low side effects associated with them. If, however, the individual really finds that the side effects are intolerable, or after that first 4 or so weeks they persist or get worse, or new side effects come, that has to be taken seriously, because anything that jeopardises a person's ability to adhere or desire to adhere to their treatment is really serious in terms of that treatment being so vital to treat the HIV dementia.
There are also lifestyle things that you can do to protect your brain health. So we can help people look at all of those issues if they're interested in addressing, say, excessive alcohol use or other drugs. You know, in a non-judgmental way, we'll look at do they want to do anything about that and how to promote their health, which will also promote their brain health.